Next Round with the Pacific Research Institute. I'm your host, Rowena Ichon. Tim and I, a PRI Senior Director of Communications, and I had a conversation with PRI Senior Fellow Dr. Henry Miller, a medical researcher and formerly with the FDA. This is Dr. Miller's third appearance on the podcast, and because of the coronavirus, he's been one of the most listened to guests all year. Dr. Miller updates us on the latest research on COVID-19, the progress of the vaccine, President Trump's handling of the pandemic, and most important, how to reduce your probability of getting the disease. Thanks for joining us. Welcome back to Next Round, Dr. Miller.
Thank you. Delighted to be with you.
So the last time we had you on the podcast on COVID-19 was in April. And back then, many medical professionals through media interviews told the public that, like the flu, the coronavirus was seasonal. And during the summer months, we would actually see a dramatic reduction in cases. Now, here we are in the middle of July, and we see coronavirus hotspots in some of the warmest parts of the country, like Arizona, Florida, and Texas. So what's the new research saying about SARS-CoV-2's behavior and its ability to transmit the disease?
Well, a lot has changed since April, as you know, Ro. The hope of a summer lull might have contributed to some politicians reopening businesses and beginning to roll back restrictions on individuals prematurely. And it's no secret that many parts of the nation are now in a bad, even dire situation. On Thursday, July 16th, we hit a new one-day high for reported cases of COVID-19. This is nationally, of more than 70,000 cases in a single day. Note that the number of cases is an early indicator of the severity of the pandemic. It's a predictor because hospitalizations and ICU admissions and deaths are lagging indicators and will certainly follow. And speaking of the number of deaths, to give you an idea of how dire our situation is, the United States has about 4% of the world's population, and we have something like 25% of the number of deaths worldwide. Now, that might be slightly overestimated because some other countries might not be counting theirs correctly, but it's still an unacceptable, unsustainable situation for the wealthiest country on the planet. A second point I want to make is that the coronavirus continues to mutate as it spreads, infects, and replicates, as do all viruses, especially RNA viruses, which this coronavirus is. And there's evidence that a mutation in the spike protein of the virus, which attaches the virus to host cells, has caused it to become more transmissible with time. Not more lethal, but more transmissible. So that could explain some of this continuing high level of infection activity. Third, the virus is spread primarily by person-to-person contact, we know now, rather than from inanimate objects. You'll recall that back in April, there was concern about getting infectious doses of the virus from groceries that were delivered and from touching things. That's possible, but we now believe that that's less likely than face-to-face exposures or aerosols in closed spaces that linger in the air. To summarize that, to become infected, you need to be exposed to an infectious dose of virus, a certain number of virus particles, and they then need to get to your eyes or nose or mouth in some way. So any way you can prevent that from occurring lowers the risk of infection. That'll be a recurring theme for me today.
Dr. Miller, if the seasonality of COVID-19 turned out not to be correct, what about this theory of waves, that we're currently in the first wave and that we could expect a second wave in the fall? Could you explain the theory behind first and second waves, and do you think we'll actually see a second wave?
Yeah, wave theory is kind of complicated, but there are several variables that can affect the waxing and waning of infections. One that you mentioned is seasonality, and the reason that occurs is that some viruses, especially flu, for example, tend to like cold, dry air. They don't thrive well in warm, moist air. So that was the theory for a summer lull, which of course has not transpired. A second is what I refer to as burnout. As the virus infects more and more people in the population, it starts to have trouble finding new targets or victims to infect. And that's not applicable here because this virus is very infectious, and insufficient risk reduction actions have been taken. You have to infect huge numbers of people in order to get burnout with a virus that's this infectious. So really at this point, the prospect of a second wave is irrelevant because our first wave is not only continuing but worsening.
So let's follow up on that, about this issue of, a second wave. What if we have a surge in cases in the fall? The demand for testing will have to skyrocket because the average person won't know whether they have COVID-19 or the flu. Is the country prepared to handle a surge in cases along with the flu? Also, is anyone studying the relationship COVID-19 and the flu? For example, could a person with the flu be more vulnerable to COVID-19?
Clearly, the answer to the question, are we prepared to handle the second wave, is no, because we're not handling this first wave very well at all. There are hot spots. There are actually increasing numbers of infections in virtually every state below the Mason-Dixon line, except for New Mexico and Colorado. Now, the superimposition of seasonal flu, and recall that the flu season begins generally in September or October and really revs up by November. If superimposition of seasonal flu on anything resembling where we are now would be catastrophic. Emergency rooms and hospitals would just be overwhelmed. Recall that in an average year, the flu infects tens of millions of Americans and kills about 36,000 on average, and requires the hospitalization of more than 1 million. So that would be absolutely catastrophic in anything like our current situation. As to the question of being more vulnerable or susceptible, if you're infected with one of those viruses, susceptible to the other, there are two countervailing factors. One is that when you've been infected by a respiratory virus like the coronavirus or flu, you get damage to the lungs that make them more susceptible to a second insult. But there's another opposing force, which is that a viral infection stimulates certain white blood cells to secrete antiviral substances called interferons into the bloodstream, and these last for a while after infection. So that's the reason that during cold season, even when various cold viruses are circulating, you tend not to be infected by one after another of them, because you have some resistance remaining from the interferons that are circulating after the first infection.
In another scenario that's different from the notion of waves, we could continue to see COVID-19 hotspots, forest fires, if you will, all over the country until we find a vaccine or achieve herd immunity, which is when 60 to 70% of the population have the infection and the population naturally comes resistant to the disease. Obviously, this is a scenario that no one wants. Explain why COVID-19 will not just go away.
To get to the number of infections that would be required in order to attain herd immunity, which, by the way, virtually never happens in natural infections. We need to have something like 200 million Americans infected. And by the time we began to approach that number, immunity in some of the people infected early would likely have begun to wane. And so possibly they could be reinfected. And we know that because we're seeing that in natural infections, the antibody titers tend to have diminished significantly by 2 to 3 months after infection. So the evidence indicates that this new coronavirus is just not a good candidate for natural herd immunity. Besides, with 200 million Americans infected, the percentage who go on to develop serious illnesses requiring hospitalization and then who go on to die would be unacceptable. We need to prevent that with mitigation strategies, clearly.
So please update us on the progress of vaccines then. As you mentioned in your writings, it's an enormous undertaking to get a vaccine to the public, and that the safety bar for bringing a vaccine to market is very high. Talk about some of the more promising vaccines, and do you think we will have a vaccine in 2021? And once we do get a vaccine, will it be effective for everyone? What are some of the risks? Is it the silver bullet that everyone is waiting?
The vaccine situation is fascinating. As somebody who used to work work on flu virus in the lab way back when. It's fascinating to see how many candidates there are in various stages of development. There are more than 100 around the world in various laboratories and being developed by various companies. 24 of those have already progressed to early clinical trials. And unfortunately, I think some of the companies and institutions involved have been announcing their research results in press releases, and none is at a very advanced stage. So it's progressing, but we're in the second inning of a 9-inning game, so it's very hard to tell. Now, let me explain the basics of vaccine development for a moment. In principle, testing a vaccine, doing the clinical trials might seem simple. You give the vaccine to one group of subjects, a placebo to a second, and then they go about their normal business and you count how many in each group develop COVID-19. But in fact, it's diabolically complex. You need to know, for example, how well the vaccine works. The FDA has said in a guidance document for industry that it'll have to be at least 50% effective, which is sort of the average for the flu vaccine in most years. How much of the actual vaccine material, the antigen, should be in each dose? Does one dose suffice to elicit necessary immunity, or do you need two, as is the case for the second-generation shingles vaccine, or do you need even more? The first hepatitis B vaccine, for example, required 3 doses at 0 time, 1 month, and 6 months. How well does the vaccine work in the elderly, the most highly vulnerable population? But at the same time, they tend to mount a poor immune response. Does immunity last long enough to make immunizing billions of people worthwhile? And how do you decide if several vaccines come along all at once, which populations will get which? So it's difficult. Also, there are potential unknown safety issues, particularly given that brand new, unproven technologies are being used to make most of the COVID-19 vaccines that are under development. Finally, the medical, ethical, and regulatory bar is necessarily very high for a vaccine intended for vast numbers of healthy people. So looking at some of our prior examples, before approval, the first successful rotavirus vaccine, that's for a gastrointestinal infection in kids, was tested on 72,000 healthy infants. The first human papilloma virus vaccine, Gardasil, was tested on 24,000 people, and the newest shingles vaccine on about 29,000. So that gives you an idea of the order of magnitude that the industry and the research community and the government regulators think is necessary for testing a vaccine to be used in healthy people. But I think the timelines that have been mentioned widely are too optimistic. I think that we're more than a year away from a vaccine that can be produced and distributed in large amounts.
Dr. Miller, one of the biggest issues confronting us in the short term is the pending return to school for millions of children this fall. There's a big debate amongst doctors and policymakers over whether and when we should reopen our schools. In some parts of the country, schools are planning to reopen this fall per normal, with few, if any, modifications. But as Governor Newsom just announced last week, many parts of California will see school open this fall online, without in-person classroom learning. What factors should local school officials consider when deciding whether and how to reopen? And are children just as susceptible to getting COVID-19 as older adults?
Well, to answer your last question first, Tim, children are less susceptible to infection and to symptomatic and serious illness than adults, and particularly less than the elderly. But it does happen, and they certainly can spread the infection, which goes directly to the issue of reopening schools. Unfortunately, the reopening issue is a mix of politics and ideology and science, and as you know, they often don't mix very harmoniously. So, like so much surrounding this pandemic, school reopening is not straightforward. Full-time in-person instruction will require significant planning, organization, and expense. It's not a matter of dictating it from on high, simply. And in areas of the country that are experiencing hotspots of infection, in my opinion, it would be exceedingly dangerous. You have to consider not only the threat to the kids themselves, which is what some politicians have done in their pronouncements, but the risk to teachers. Some 38% of whom in the U.S. are older than age 50 and so are in a vulnerable group, but also all the support staff, school bus drivers, and janitorial staff. And more of the janitorial staff and cleaners will be required for the deep cleaning that's necessary for in-person facilities where in-person teaching is occurring. Now, a useful guideline came just on July 15th from the National Academies of Science, Engineering, and Medicine on school reopening. So their overarching recommendation was, which I agree with, was that school districts should prioritize reopening schools full-time, especially for grades K5 and students with special needs. But that's philosophical and not practical. So the report goes on to recommend that schools and school districts take certain precautions to protect staff and students. And these included providing surgical masks for teachers and staff and requiring that they all wear them during school hours, providing hand washing stations or hand sanitizers for anyone who enters a school building, and minimizing contacts with shared surfaces, limiting large gatherings of students, such as during assemblies and in the cafeteria, reorganizing classrooms to enable physical distancing, such as by limiting class size or moving instruction to larger spaces. And of course, that implies more teachers if the classes are going to be smaller. And finally, prioritizing cleaning, ventilation, and air filtration. So, as I said, all of this requires significant planning, organization, and expense, sometimes huge expense. More teachers if classes are to have fewer students, more janitorial staff, and new equipment for improved ventilation and air filtration.
So the spike in cases all over the country is attributed to the cavalier behavior of younger people who have flocked to bars, restaurants, and beaches once they open without the recommended preventative measures such as masks and social distancing. So many young people think that if they get it, they'll get through it well enough. But as we know, not everyone bounces back 100% from the coronavirus. People can suffer long-term damage such as lung scarring. Dr. Miller, discuss some of these possibilities and long-term problems that one could have.
You've raised two important issues, Ro. The first is that widespread noncompliance with mitigation strategies, such as masks, and largely responsible, I believe, for the predicament that we're in now. So we need and should have had very aggressive public service announcement campaigns with dignitaries and celebrities of all stripes, politicians, rock stars, actors, athletes, think tank scholars, and also good public examples by politicians who should portray wearing a mask as being smart and public-spirited instead of defeatist in some way. We clearly haven't had that. The second point is the misconception that COVID-19 is akin to a bad flu. You feel terrible and are in bed for a week, and then it's done and gone. Although the coronavirus most often presents with dry cough, difficulty breathing, and fever, there have been numerous reports of non-respiratory manifestations, including loss of smell and taste, confusion and cognitive impairments, sudden muscle weakness, seizures, strokes, kidney damage, transmission of virus to a fetus via the placenta, and a severe pediatric inflammatory syndrome. Even after these manifestations disappear, recovery is sometimes incomplete, with some patients experiencing long-term adverse effects that are like a condition variously known as myalgic encephalomyelitis or chronic fatigue syndrome. Chronic fatigue syndrome is the more common name. And the signs and symptoms of that are fatigue, loss of memory or concentration, sore throat, swollen lymph nodes, muscle or joint pain, headaches, non-restorative sleep, and extreme exhaustion following any kind of physical or even mental exertion. And that often lasts for a very long time in chronic fatigue syndrome, even for years. And we can't know yet whether for how long these CFS-like symptoms will last after coronavirus, but many people are now several months out and still experiencing them. It's interesting that about a week ago, CNN anchor Chris Cuomo, who suffered an acute bout of COVID-19, said on air that he's experiencing some of these post-viral infection symptoms. So, and it's not uncommon. This is not a trivial illness, and that's another reason that we can't let this spread in order to get natural herd immunity or burnout.
Some scientists now believe that coronavirus can be spread through aerosols, in other words, airborne. Do you have an opinion on this? And if it can be spread in aerosol form, are the precautions we're taking, wearing masks, socially distancing 6 feet apart, washing our hands constantly, are they enough? Would we have to take even more drastic measures?
Well, we've known for a long time that the virus can spread both from larger droplets that come from the nose or mouth with coughs or sneezes, or even singing, such as in a church choir, which caused a major outbreak, but also by means of much smaller droplets through what are called aerosols. It's just been unclear what the relative predominance was. It's still not entirely clear, but we know that both can spread it. The point is, I'll return to my theme about it all being a matter of probabilities. The aerosols are more insidious in a way because the particles do remain in the air for long periods. They waft around. They drop to the floor and evaporate. And that's why the risk is higher in crowded indoor spaces with poor ventilation, and may help explain super spreading events reported in places like meat packing plants, churches, and restaurants. Again, the relative contribution of droplets, larger droplets, and smaller aerosols is unclear, but the approach to it is exactly the same. You do everything you can to avoid the probability that you'll be exposed and get an infectious dose.
President Trump has taken a big hit in the polls on his handling of the coronavirus pandemic. What are some of the things that the Trump administration has done right? What have they done wrong? And what should they be doing now to prepare for a possible surge in the fall?
Well, first, the positives. Early on, the ban on travelers from China was a good and timely idea, as was invoking the Defense Production Act to produce enough personal protective equipment and ventilators. The administration's announcement of Project Warp Speed to accelerate the development of therapeutics and vaccines was also good. As part of Warp Speed and through other vehicles, the federal government has been funding a lot of R&D on therapeutics and vaccines. Again, very good, very important, especially insofar as they've provided money to start building bricks and mortar facilities for vaccine production, even before many of the vaccines have been proven. That speeds up the process significantly. And finally, the FDA's guidance to industry about vaccine development several weeks ago, I think, was quite sound. FDA is going to try to accelerate the process, but not cut corners in a way that will compromise the safety of those who get these vaccines. In other ways, however, the feds have not done so well. Initially, CDC distributed flawed tests for COVID-19. They were contaminated. They were completely worthless. It took 5 weeks for CDC to send out a second round of tests, which lacked one component that was in short supply on the market, and so testing was very, very tardy. Also, FDA permitted fraudulent or inadequately validated tests, both for the viral genetic material, that's the swab test, for active active infection, and also tests for blood antibodies to the virus, which would indicate that a person had the infection previously. Another point that I find unconstructive is that the happy talk about the pandemic fading away and minimizing the importance of the pandemic. We see that, I've seen that a lot in the press conferences of the White House Coronavirus Task Force, for example. Another example is the reluctance of some senior officials in the government to wear masks, politicizing the wearing of masks. The president and vice president, I think, have been culpable on that point. Likewise, some in the administration have encouraged protesters to demand premature reopening. And again, I think that's contributed to where we are now with the rise in cases of infection, hospitalizations, and deaths coming. Actually, I should say the number of deaths has trended downward with time. And there are a number of reasons for that, but there are still far more than are desirable or necessary given the epidemiology. The blanket demands for reopening of schools we've talked about a little bit, and that's another thing that I think is unconstructive coming from the White House. And finally, the denigration of some of the nation's leading public health experts, like Tony Fauci, from the White House, is really, really damaging and counterproductive.
Finally, Dr. Miller, we still know very little about the coronavirus, especially our chances of being infected. On top of that, politicians and health officials have given the public mixed messages. So as we close, how would you advise listeners on how to reduce their chances of getting COVID-19?
Again, as you know, I addressed this in an article on Human Events, May 9th. It was entitled, "The Name of the Game is Minimizing the Probability of Infection." And primarily, I recommend the things that public health officials have been saying all year, which is wear masks, preferably of hospital quality rather than homemade if possible. Second, social distancing, which means not only the 6-foot rule, 6 feet is not magic, but also limiting close contact with other people to only those that are essential. Third, frequent hand washing and use of hand sanitizers. Fourth, improve the ventilation of your living or working space insofar as that's possible. For example, by leaving windows open or upgrading heat and AC systems, or by buying high-quality room-size air purifiers. And a policy recommendation is encourage political leaders, local, state, national, to mandate and enforce mask and social distancing measures.
Thank you so much, Dr. Miller.
It's always a pleasure. Thank you.
Special thanks to Dr. Henry Miller and Tim Anaya. If you like this episode, please tell your friends to subscribe to PRI's podcast at iTunes, Google Play, Stitcher, or TuneIn. And now we're in iHeartRadio. And please do us a favor and give us 5 stars. You can also listen to our podcast on PRI's YouTube page, youtube.com/Pacific Research 1. That's the number 1. Thanks for listening. I'm Rowena Itchon. Hope you'll come back again for next round with PRI.